Kia ora tātou, everybody. Bruce Arrell's my name. I'm the director of the Goodfellow Unit. Welcome to tonight's webinar, where Dr. Owen Sinclair is just going to open up with the karakia. Over to you, Owen.
Tēnā koutou katoa, hei karakia te matatanga. Tukua te wairua kia reri ki ngā taumatahi arihi I a tātou mahi mi tā tātou whai. I ngā pikanga rātou mā, kia mao, kia ita, kia kōrere ai ngāro, kia pupuri, kia whakamaua, kia tina humaye, huiye, tā kia.
Thank you, Owen. So tonight's webinar is about immunisation. With our borders open, there's more chance of diseases like measles coming back into New Zealand and spreading into the community. Our first speaker is Dr. Bryn Thompson, who's a specialist GP from Auckland Regional Public Health. He's going to talk about measles and its epidemiology, vaccine coverage, signs and symptoms, and action to take. So over to you, Bryn.
Thanks very much, Bruce. Kia ora, everybody. Welcome to the webinar. I hope, and as I see on my screen, I hope I don't steal the other speakers' thunder in any way. So we haven't compared notes. So when Owen and Chris come to speak, as Bruce said, I'm a GP. I'm one of the medical team in Auckland Regional Public Health, where I've been for the last 5.5 years. And although we've just obviously gone through COVID for the last 2.5 years, we are certainly gearing up for what we expect in the not too distant future will be measles coming to New Zealand again. So we're going to cover these in the next few minutes, why measles is so important, the epidemiology, a little bit about vaccine coverage, and then really those take-home messages. What is it important in primary care particularly when it comes to measles? So why is it so important? And I do apologize if this seems so simple, but sometimes these key messages are what needs to be driven home. Measles kills. And if we look back just 4 years, there were more than 140,000 deaths, and mostly amongst children, according to the WHO. And who can forget Samoa in 2019 with over 5,000, approaching 6,000 cases, and those 83 deaths, particularly amongst children under 5. And sometimes those statistics just seem just like numbers, but how incredibly tragic. 25 deaths per 10,000 amongst those children under 5 in Samoa. We forget sometimes too the significant hospitalization rate of measles, and in 2019, particularly in Auckland, at least 35% of cases were hospitalized. And there's an equity issue there with far greater rates amongst Māori and Pacifica. And you can see those children under 5, the cases over 50%, nearly 52% ended up in hospital as a result of the complications or pneumonia secondary to measles. Measles takes a huge burden on those cases, their families, both health-wise and of course financially. But more than that, and we've learnt this in the last few years, the massive impact measles has on the immune system. It was 20 years ago in Japan, they realized that it's not just a respiratory virus, it's an immune modifying virus. And just 10 years ago, really this realization that measles causes immune amnesia. And there's many papers being written on it now that it just really wipes out that already existing protection against many other viruses, with a paradoxical, really strong protection ongoing against measles. So studies have now shown that it's about 3 years of recovery to, again, build up that immune system to fight other viruses, which is similar to, of course, the first 3 years of infancy. Measles is so highly infectious. Of course, if we compare to flu, having had quite a bad flu A season this year, with an R0, the number of cases on average people will spread it to 1.5, so between 1 and 2 people each. Compare that to the 2020 COVID strains with an average of about 3. More recent Omicron, which got towards 9. Measles puts them in the shade with an R0 of approaching 18 in some cases. Now, of course, that's in an unimmunized population. But as you'll hear throughout the evening, that is part of the problem. We have far too great folk who are unimmunized across New Zealand, the whole country. It also exacerbates inequity. And of course, we've got somewhat used to the option of monarchy, of well-being, of some previously called welfare with COVID. But we don't expect that to be the case should there be a measles outbreak. It's more likely that families would rely upon food banks, upon work and income, upon other providers. And we worry that the families who can afford it the least always have the biggest impact. Measles exacerbates inequities. So just to some basics of epidemiology. And we know, and sometimes we get calls occasionally saying it's measles. And of course, we know there is no circulating measles in New Zealand. Of course, New Zealand is one of the many countries that's been declared measles free. And we were fortunate not to lose that status in 2019. You may have seen in the news some concern that there was measles in Fiji, but it's been encouraging in the last week, in fact, to see that after further testing of those samples in Australia, they've said it's not measles. But there was a single incursion in Australia just a few weeks ago, and we're very fortunate there were no secondary cases, despite quite significant travels for that particular person. But what we do know is even if it's not right on our doorstep, it's pretty close. It's only a flight away. And there has been a surge of cases around the world in 2022, mostly in sub-Saharan Africa and South Asia, but not exclusively there. When it comes, of course, it'll probably come across the air border as a returnee, a traveller who's gone to some nation and come back, or possibly just a traveller visiting New Zealand. Unlike the last couple of years, our borders are open and it's just so easy to travel, albeit a bit more expensive than previously. So this week, we see this headline from Zimbabwe. See this, it's just incredible. Nearly 700 children have died in the last 5 months in Zimbabwe, over about 6,000 cases. So if that's, I mean, it's probably underreporting, but that's astonishing. And they say that it's particularly amongst those of a particular Christian sect who don't believe in immunisation. They've actually got they've got an average immunisation rate in Zimbabwe of about 85%. So you can just see, despite that, the huge impact it's having there. Some of our cases that have come into New Zealand previously have been from Philippines, and there is actually a bit of an outbreak in Philippines as well, where there is even lower vaccination rates, very, very low rates. And so we certainly worry about the Philippines as well. So our vaccine coverage is very low. And as I'm sure Owen will share more, it's worse than it was 3 years ago. And it's very inequitable. Well, I'll show you that in a second, some of the inequities. But first, let's have a look at this map. Here's a heat map of the cases in Auckland. So sorry for those outside of Auckland, but this is where the majority of the cases of measles were 3 years ago. And you can see those hot spots, the three different serotypes, the B3, the two different strains of B3 and D8, and then the yellows that weren't typed. And if you just focus, you'll see the great majority of the cases through counties, through South Auckland. Although it started and it will play it again, if we could see it there initially through a lot of Waitematā, through West Auckland, and relative sparing of the CBD, of the central suburbs of what was ADHB, but also the eastern suburbs and North Shore. And you can just see that huge focus that was particularly in South Auckland and the suburbs that can perhaps afford it the least. Unfortunately, those remain some of the least vaccinated suburbs across the city. If we look at the Ministry of Health data that's released, and this is data that's freely available on their website and released every 3 months, you'll see if we look particularly at 24 months, obviously the ideal is vaccination on time every time. And so most children ideally would have received their 2 MMR vaccines at 12 months and 15 months. But even if we leave it not just at 18 months, which would be nice, but just give another 6 months grace, you'll see the really astonishing vaccination rates, knowing that we need at least 95% coverage for good protection to make a difference in terms of population health. So if we look there nationally, 83%, and then particularly focus on the Māori rates. Across the country, 67%, 70% in Auckland. Look at that statistic in Northland, 56% coverage at 2 years old for both MMRs essentially amongst Māori. This is, as you'll hear more, a tragedy waiting to happen. This is some new mapping. So what we've done is taken the MMR, and I've just looked here at both MMR vaccines at age essentially 2. And so the bluer the map, the bluer the suburb, the more fully vaccinated these children are. So here we are looking at Asian children fully vaccinated in this age group. And you can see if we look at this, really 80 to 90% with light blue or dark blue across most areas of Auckland. Now, if we take that to European and other, you'll see there's a little bit less blue, and particularly through counties, you'll see just a few more orange or even yellow or red suburbs. And just that's not exclusively there. Now, this relies, of course, on quality data, but with what we're given from the MMR database, this is what we can see. Pacifica, you can see a lot more mottling across the city. You'll see a lot more orange, particularly in certain areas. White suggesting there's no data to map in those particular areas, of course. And here we see Māori rates. And here you'll see, particularly in Waitematā through counties, it's yellow or orange and pockets of even touching red. These are the same suburbs I just showed you in the map from 2019 that would be most likely to have the biggest impact on our toddlers again. And this is, of course, we're not mapping here those who face the immunity gap, those who are perhaps 15 to 34 who, because of issues with the NIR not being developed, about the Wakefield scare, amongst so many other reasons and the change of the schedule, who also have fallen through the cracks. And as you know, there was planned for a catch-up campaign that really hasn't taken off fully. So this is, although we're focusing here on the under fives who are the most likely to end up in hospital, it's the pregnant woman of the future. It's so many others who are not covered by measles vaccines. So with that in mind, let's take it back to primary care. And what do we need to do as practitioners at the coalface? Obviously, the first step is to, when you're seeing someone, whether it's in the red stream ideally, is just take that good history. And it's so helpful for us in public health. Measles follows a pretty clear pattern. And when we're notified, it's so great to hear about the 4 Cs, the cough, the conjunctivitis, the Koplik spots, and the coryza. And you can see these precede the rash. And obviously the fever is the predominant symptom you can see. And the rash onset, if we call that day 0, that's just a slight change. We've linked it up across the country in line with our terminology we've used with COVID. So the prodrome are sort of in the days up before, particularly day -1, -2, but potentially up to 4 days prior. So the infectious period is typically 9 days, day 0 and 4 days either side from day -4 to day 4. And you can see just the transition. So a history of what was the prodrome, when did the rash start? And that rash onset day is such a key date that's so helpful for us. Obviously, understanding those symptoms and getting a good history, but particularly when do they commence? And those other key things, are they immunized? And if you can share that immunization with us, that's key. Of course, we look on the National Immunisation Register, but if the records aren't there, they're a visitor perhaps, or they're recently immigrated, all of that is so helpful. And particularly travel too. Where have they come from? What plane did they even travel on if they know it? And the precise dates. If we know someone has traveled, immediately there are a much higher index of suspicion than someone who is here. Similarly, if someone has had 2 MMR vaccines, the MMR2, that's useful. Have they had a recent MMR? Could this be a vaccine reaction? Also really important. And of course, all this is on the health pathways, and these are kept up to date and currently being updated with some of the latest information on measles. Throughout it, remembering, just like COVID, isolate the case, not necessarily the household, but isolating the case or the suspected case. In terms of investigating, this has changed a little bit. And those of you who remember that previously there was quite precise window of time for PCR testing. So from the rash onset to about day 3 or 4, it was thought the PCR was suitable. In conjunction with the lab, but just understanding, it's now been pushed out nationally to 7 days, which makes it a whole lot easier. So as a primary care practitioner, the real test is a PCR swab, either nasopharyngeal or potentially a throat swab with a classic red flocked swab. If it's beyond the 7 days, talk to public health, because thinking about whether it's appropriate to do that and serology, but this is being updated on health pathways and it's not currently there this evening, but will be in the next few days. So again, remembering that. And please, we'd ask if you can notify public health, whichever area of the country you're in, on suspicion. And the service is available 7 days a week. It may be like here in Auckland with our e-notification form that's sent through, or speaking to the local medical officer of health. Their service is certainly 7 days. We'd so much rather know in advance. It helps us prepare in those high index of suspicion cases which is incredibly helpful to know rather than just get a lab notification of a positive measles case. So what can we do? Just some simple tips, and I'm sure you're doing this anyway, but just a reminder. Opportunistic vaccination. When people are in the consulting room for an unrelated matter, if you can check if there's evidence that they've had 2 measles MMR vaccines, and just taking that opportunity. It is funded if there is no record, so please consider that. Particularly think about that gap in the 15 to 34-year-olds who may not be covered. Noting that we still count that those who were born before 1969 are presumed immune, but anyone younger we would not presume so. Set those recalls. What is your practice vaccine like? And remembering that equity, focus on those who are made more likely to have slipped through the cracks through Māori, Pacifica, but all groups. Remembering that those who bring measles in may well have travelled. So if you are having a pre-travel consultation, consider MMR as routine for people who are travelling, and that will reduce the chance of it coming into the country. Check your staff are immune. It's such a burden on a practice if staff have to be stood down or isolated as close contacts. And so helpful to just know that all of the staff in the building will not have to be stood down. This is not like COVID. If you are fully vaccinated, you do not need to isolate. But if you've had a single MMR, you may well have to isolate, or of course, none at all. And of course, being familiar with the documents, those on the Whatu Ora site, and particularly the local clinical health pathways. I think, and this may be covered soon, I'm not sure, but I always like to go back and think about those who are vaccine hesitant. And all the studies show that there are far more who are vaccine hesitant than those who are vaccine refusers. And study after study across the world shows that a trusted healthcare provider, yes, you won't make a difference every time, but in some studies, at least 15% of the time, unvaccinated people will actually choose to be vaccinated when their healthcare professional actually mentions it and discusses it. It can take time. It can be taking several times to mention it. But primary care is a place that will make the most difference to improving our vaccination rates in Aotearoa. So that's what I wanted to share. We are worried. Measles will come. We don't know when, but it's best that we are prepared. Thanks very much, Bruce.
Okay, thanks, Bryn. If you've got questions, put them in the Q&A box and we will answer them either as we go or at the end. Our next speaker is Dr. Owen Sinclair. He's a paediatrician from Te Whatu Ora at Waitematā, and he's going to look about childhood immunisations. Are we looking at a crisis? Over to you, Owen.
Yeah, so tēnā koutou, my name's Owen. I'm a paediatrician based at Te Whatu Ora Waitematā, which is the old Waitakere Hospital in West Auckland. And as you can see, I'm chair of 2 groups now, the National Immunisation Task Force, which has recently been set up, and also the chair of the Metro Auckland Immunisation Clinical Governance Group. And just to give away maybe my conclusion, both of those were set up to try and deal with a crisis. I've also been heavily involved in the CVTAG and the COVID space, being on the highest technical advisory group and the vaccine monitoring group. So yeah, it's probably just going to be a double up, but just to it bears discussing again that immunisation is the greatest of all of the medical treatments that there is. It's unsurpassed in saving of lives and cost effectiveness. And with regarding to measles in particular, there is no cure for measles, but there is almost 100% way to stop getting it. One of the diseases that has killed millions of children through millennia. And also, I mean, where would we have been through COVID if there hadn't been a vaccine? I don't know what would have happened. So just some data again. So this is the immunisation coverage in New Zealand by 2 years that have been presented. So it's total New Zealand, European and Māori. And I think the previous speaker mentioned that the rates are lower than 2019. In fact, the rates are now lowest as they've ever been recorded. And if we look at the graph, as you're all fully aware, rates were started recording in 2009 with the setup of the National Immunisation Register. And then there was an immunisation push, or it was part of one of the 6 immunisation targets, and we were able to elicit the bit in the middle where the New Zealand, European and Maori rates pretty much coincided, although neither of them got to 95, was widely celebrated as a success. From about 2017, the line started to diverge, and then when COVID happened, there was a big divergence of the two rates. Now, it's interesting to note how this was achieved. So this wasn't achieved by repairing the primary system of giving immunisations. It was done by putting in a secondary system, so people would register those who were not immunised, and that then DHBs would follow them up with outreach immunisation. That system started breaking down in 2017 and completely collapsed through COVID because everyone went off to give COVID vaccinations. And as you can see, at the 6-month level, any sort of improvement was really absent. The gap between Māori and New Zealand European never diverged at all. And this is probably the best measure of how the initial immunisation system is functioning. And it shows the massive gaps that are there, the difficulty that New Zealand has had in immunising, providing the 3 primary immunisations. And if we add in all immunisation groups, all ethnic groups that are recorded, so essentially Asian people literally on the way home from birth go to their primary practitioner and book a vaccination, and that's why they're so high. But what some of the startling features are that the rates are now lowest as they've ever been recorded, and the largest, the most probably biggest predictor of someone's immunisation status in New Zealand at 6 months since 2019 is their ethnicity. And that gap, you can see it's almost train track straight between each other. We've never been able to close any gap between the two groups. And it's one of the glaring examples of ethnic disparity and systemic racism within our medical system. Rather unsurprisingly, the major disease that the primary immunisations are trying to resolve is pertussis, and Maori rates of pertussis have always been much higher. You see recently with the borders closed, there's hardly been any at all, which is a good thing. But the paediatricians of the world are waiting for that. Pertussis is just like measles, there's no cure, and we hate it. And you can see that the severe disease of pertussis, this is the admissions to the only paediatric ICU unit in New Zealand, is heavily weighted towards both Māori and Pacific rather than other groups. So there was previously mentions about vaccine hesitancy, and it has been one of the main focuses of much of the immunisation improvement throughout New Zealand, but I would like to propose that it's a myth, and it has always been a myth. The studies in New Zealand on particularly of Māori, whether they're hesitant, have shown that Māori actually have much higher intentions, of immunising than other groups. And so the graph on the right is from a study done out of the University of Auckland called Growing Up in New Zealand, where they followed thousands of pregnant women, and they asked them antenatally, what were your intentions to immunise? And as you can see from that, Māori had some of the highest intentions of immunising, but when it came to 5 months, they had the lowest rates of completion. And also that graph that I showed you before at the 2-year level, where Māori rates coincided with European rates, was also completely consistent with Māori not being hesitant regarding immunisations. And just the hesitancy in New Zealand in total, that almost 97% of eligible people in New Zealand got the COVID vaccine. So to say that there is widespread or large amounts of hesitancy or refusal of vaccine in New Zealand is not borne out by any statistics or study. And so the other thing that's vitally important, and I know it's been said before, is is timing. And so it's not just good enough to give the vaccines, which is why that 2-year figure never reduced the rate of achieving that parity of pertussis. You need to give them on time. And if your health system collapses, as it does from time to time around the world after they fix the sewage and the water, the very first thing they bring back in is the 6-week vaccination. And the longer you wait for it, the worse it is, and the more diseases that happen. And also importantly, the single biggest predictor of a child completing their immunisations is if they get the 6 weeks vaccination on time. So yeah, this is another bit of data. This is the up-to-date, hot off the press 18-month vaccination rates in Aotearoa, and it shows that Māori rates of completed vaccination at 18 months are now down to 40%. I was just told in South Auckland, the 6-month rates for Māori is 31% as we speak. So not just a disaster waiting to happen, it's a disaster that will happen, just like it occurred in Samoa, whose immunisation rate when the measles arrived to New Zealand was 31%. So what are we doing? So the first group that we looked at on was we did a deep dive into the immunisation process in the northern region. That included, so that was counties, Waitematā, ADHB and Northland DHBs, and we all sat down and did a deep dive into the system. This was in 2021. And this is how we analysed the system. We took it from start to finish, looking at all the processes that occurred on the way, and trying to find out what's going wrong and what could be improved. Just on that graph, some of the things that are really difficult is that there's no one actually in charge of the immunisation system in New Zealand. There's no single body that runs it. There's no one that's tasked with immunising an individual child. Primary care does not have to accept a referral for immunisation and doesn't in some cases. And also there was no one person who's in charge of or responsible for following up missed immunisations. It really is a bit of a chaotic system. In fact, it was so chaotic, we couldn't find a single part of the immunisation system that was functioning normally from top to bottom. And we made all these recommendations, which were 56 separate recommendations, and 34 of them we felt were immediate. We're trying to deal with some of them. Unfortunately, since then, things have gotten considerably worse, which is why the other two task forces have been set up. So if we look at the immunisation process, and although things are free, there are lots of barriers. There are barriers at opening hours, there are barriers at transport, there are barriers with poor people and Māori. They only have one car, and the person who takes the car is the one who's earning the money to pay for the food and rent. And also people who have low paid, low status jobs, when they ask, can I take my child for immunisation, they say no. So if you've got a system where there are barriers, those that are affected by the barriers will be adversely affected in any way at all. And that is the case with immunisation that occurs in New Zealand. So how could we get things done? So this is one presentation of how we could make things better and try and resolve some of the systemic changes that occur. So people think that the immunisation journey for a tamariki or a pepe starts at birth. It shouldn't. It should start a long way before birth. It should start at their first antenatal visit, like that. And so really good evidence that if a pregnant woman or a hapu mama receives an antenatal vaccination, it's highly predictive that they will then get their child vaccinated. And the studies into views on Māori and other groups show that the main reason that they want to get immunised in pregnancy is to protect their child. Unfortunately, those same studies show that a large amount of pregnant women are not actually told, still aren't told about the option for having immunisations. And then the second group, the second place where it could be, where action could be taken is that when a child, the vast majority of children in New Zealand are actually born in hospital. And so at that time point, it's a really golden opportunity to maybe make a booking a la what Asian families do at the time of discharge from hospital. Some slick IT would be great there. And I know that sounds very easy coming out of my mouth, and slick IT is actually very hard and very thing to make, but some sort of book my vaccine app or something at the time of birth given to mothers in hospital would be great. So these are the barriers to Māori getting immunisation. They have reduced access to communication and travel. They really don't trust the system in any way, shape or form. Very few Māori, including myself, trust the system. And also there are significant issues in the provider arm which more recently have gotten a lot worse since it was made, with workforce shortages and other things, and just complete burnout of primary care and having to prioritise things. The things that have been that have worked and have been done to broadening the amount of places that immunisations could occur. Almost 45% of all vaccinations in the COVID occurred in pharmacies. Pharmacies are now registered to give vaccines down to 3 years, but also giving people access at times when they can actually go to get an immunisation done. So anyway, that's just expanding on the what could possibly occur at that birth time. So targeting the at-risk groups that we know. So the number one group would be Māori. And so ensuring that we know whether they will be in 6 weeks and whether they can get to a place with immunisation, or we have to take the needle to them. And we're not talking about huge numbers here. So the vast majority, if you're working in a practice, would only have to increase the immunisation that you did on a tamariki Māori, maybe one every few months, to really raise the number. For example, in my DHB, which is actually the second largest birth centre in Australasia, there are about 250 Māori, tamariki Māori born or pepe born every quarter. About 50% of them get done. So it's actually only one a day in that quarter to get that up to 95%. So why is it caused? So we looked at that that breakdown of the system. It had a huge number of reasons about why it wasn't functioning. And so one of the reasons is this, that the yellow it can be explained by a socioeconomic gradient between that makes access harder for one group over another, in this case, Māori over Pākehā. And the socio-economic gradient does explain at a single point of time of why there's a gap, but it doesn't explain why that gap occurs over a long period of time and has not closed. And as you can see in this graph here, that Pacific have at least as bad socioeconomic status as Māori, but Māori of lower, which would indicate there's another factor involved for Māori rather than just socio-economic factors. And the other one is the system being completely unable to reduce any of those gaps over the length of time. There's very few ways, there's very few things that explain these observations over time, other than a system that is essentially systemically racist. So are we looking at a crisis? The crisis has been here for a while, actually. We're unable to achieve even close to adequate levels of immunisation, even for Pākehā, let alone Māori and Pacific. Those people are the most vulnerable. The system just does not work as a system from top to bottom. It's pretty haphazard. There's no structure to it. There's no leadership. There are no standards of care. There are no guidelines. It's unsustainable. So the system completely breaks down at times of pressure. And it leads to significant vaccine preventable disease, and it never really were. So are we looking at a crisis? And the answer is yes, we are. So I have an advert here. I'm sorry, I was forced to show you this. That was made, and it is something that I'm sure that everyone here understands. It's a function that can be added to MedTech. Now, this function is called an immunisation catch-up tool. And if you, like me, find it really difficult to work out what immunisations to give at what time, then this is the answer for you. You don't have to look up the vaccination textbook. You don't have to pick up the phone to IMAC. You can just plug in the child into the immunisations that they have, including the weird ones like meningococcus and all that sort of stuff, and it will tell you what to do. It's been developed by, I can't remember her name, but this is the stuff, I'm sorry to this, but it has been rolled out, it has been tested, and hopefully it will save everyone heaps of time. They don't have to pick up the phone or look up an app or look up the immunisation handbook, which I struggle to do, and it spits out even all the weird ones. So there's all these weird exceptions for things like varicella and all that sort of stuff that are all different, like this sort of thing. So this is here. You will hear about it. It's really good. It's got no cost to to install, what does it say who to ring? It's got some number to ring there. I'm going to have to email you all about that. I was forced to actually do it, but is everything on this side? Yep. Anyway, thank you very much for listening.
Okay, thank you very much, Owen. And our next speaker is Chris Maher. He's a Senior Specialist Advisor, Health Emergencies at Respond Global Health, and he's going to talk about the international situation. Remember, if you have questions for the panel, pop them into the Q&A box, not the chat box. We've got some questions here. Chris, over to you.
Thank you very much, sir. Very interesting listening to Owen and Bryn talk. My name's Chris Maher, as Bruce has already mentioned. I worked for WHO for nearly 3 decades, which gives you a general indication of my level of intelligence. I wasn't smart enough to get out when I could. When I did finally get out, retired at the end of 2020, and I got persuaded by a colleague of mine who's running an organisation called Respond Global in Australia, a gentleman called Ian Norton, to join him and do some work with them. So foolishly, instead of sitting in the Queensland sun toasting my toes on a regular basis, I'm spending too much time working. Anyway, let me, as Bruce said, my objective is to just give you a bit of a run through of what's happening globally. I used to do a lot of work with immunisation when I was working with WHO in different regions, including a lot of work on measles and a lot of work on polio. I've stolen some of my colleagues, my former colleagues' data for this, and some of it has already been mentioned actually by Bryn and Owen. If we have a quick look at trends in recent years, and I'll show you some of this as we go along. Reported cases of measles have really been declining substantially globally over the past couple of decades, and most particularly in the last 20 years or so. And it's all basically as a result of vaccination and improving levels of vaccination across the globe. In 2019, there was a bit of a hiccup, change in the usual trend of case numbers going down year by year, and we had a pretty significant peak in terms of numbers of cases reported in recent years, driven in particular by very large epidemics in DRC in Africa, Democratic Republic of Congo, and in Madagascar. But there were also other parts of the world that reported outbreaks in 2019, including Ukraine in Europe, and in our region, Philippines and Samoa, as Bryn and Owen have already mentioned. Following the big outbreaks in 2019, the COVID-19 pandemic started in 2020, travel got locked down, and we ended up with, again, a very rapid drop in case numbers for measles being reported to the lowest numbers that we've ever had reported in 2020 and 2021. Now, there are a number of caveats to that. Disease reporting is only as good as the surveillance system is. And a number of issues, of course, there were a number of issues around general disease surveillance system operation during the COVID pandemic period, because health systems were fully occupied with COVID and a lot of things suffered. Nonetheless, I think the trend is probably correct. I mean, while the absolute case numbers, you've got to take them with a grain of salt, the trend of cases dropping very rapidly in 2020 and 2021 is probably very correct, and is certainly associated with the changes in human behavior and human contact in the period of the COVID pandemic response. In sort of parallel to that, you've had immunization coverage improvement that was actually slowing down over the second decade of this century. So from about 2010 onwards, measles vaccination coverage was still sort of improving, but was plateauing essentially globally. And then with the COVID pandemic coming on, there are concerns, I think very valid concerns. We'll look at a little bit of the not very clear data, but reasonable data indicating that in some places at least, basic vaccination services did suffer during the COVID pandemic response and immunisation coverage dropped. So this is just, as I promised, to show you the chart of global reported measles cases. I come back to that caveat. I mean, I don't believe for 1 second that there were only 4 million measles cases in 1982, nor do I believe for 1 second that there were only 100,000 measles cases in 2016. Surveillance systems are not that good. They're a lot better now than they were in 1980. But nonetheless, the number of measles cases reported should be regarded as a trend rather than as an absolute. We really don't know how many cases there were in 2016. What we do know is when we see that peak in 2019, that is a very real event. It's a direct result of the epidemics that we saw, the outbreaks that we saw in Africa in particular. This next map just shows just a representation of what's happening with coverage with measles containing vaccine, the first dose of measles containing vaccine, and you can see what's happening with the coloration. The darker the color, the higher the level of coverage. You can see the areas where coverage is lower. Of course, in our region, we know Papua New Guinea has struggled for some years now with sustaining high levels of vaccination coverage. You can see slightly lower levels of vaccination coverage in parts of Southeast Asia, in particular the Philippines, which has suffered from measles outbreaks quite consistently over the past few years, but also in some other areas of Southeast Asia, Cambodia, Laos, and Myanmar in particular. But the biggest areas with the lowest immunisation coverage are countries in West and Central Africa, and it's those countries that have been suffering from the largest of the epidemics that have occurred recently. This map just shows you the reported measles cases in 2019, and it's showing you that much darker coloration in the Democratic Republic of Congo and Madagascar, where there were very large outbreaks. I mean, getting up to 500,000 reported cases. Of course, that's a fraction of the number of cases that actually occurred, but they were clearly very devastating outbreaks, and they caused a lot of death and a lot of severe illness. Sorry. Just coming to Samoa and the recent experience of the outbreak in Samoa in 2019, and both Owen and Bryn spoke about this. I just want to raise a few quick lessons that came out of that outbreak. I mean, in terms of the absolute number of cases, of course, the population of Samoa is not very large, it's around 200,000 people, and about 6,000 cases of measles reported, 5,700 plus. In absolute terms, globally, this wasn't a huge number of cases, but in the context of Samoa, it was a very big outbreak, and the impact was significant. Hospitalization rates were, well over a third of cases ended up being hospitalized, and as our previous speakers mentioned, we had more than 80 deaths. Nearly all of those deaths were in kids under the age of 5 years. Around 90% of those deaths were in kids under the age of 5 years. If you contrast that with the outbreak that occurred in Tonga in the same year, and both outbreaks had the same origin, by the way, which was New Zealand. Measles transmission in New Zealand, and travellers picking up measles in New Zealand and bringing it into Samoa and Tonga. The outbreak in Tonga, while significant enough, more than 650 cases, the vast bulk of those cases were not hospitalized, and they had no deaths, zero deaths. Very different result between the two situations, and the main reason why there was a very different result is because the vaccination status of children in Tonga was much better than the vaccination status of children in Samoa. And the deterioration in Samoa, I was listening when Owen was speaking, and very, very interesting to look at his graphs and the declines in immunisation coverage in New Zealand. As late as 2013, with the first dose of measles-containing vaccine in Samoa, coverage was greater than 90% in children at 1 year of age. By 2018, as he also mentioned, that had dropped to 30%. So in the space of 5 years, the impact of that decline in immunisation is borne out by these circles in front of your screen now. Nearly 10 times as many cases as there were in Tonga, far more cases in young children, therefore the severity of the disease was much worse, far more cases in completely unimmunised kids, so the severity of the disease was worse, and all of these things playing into a much more serious epidemic than that suffered by Tonga. Flicking on quickly to current immunisation coverage, this is the latest data that WHO has and comes with all the caveats surrounding the data that WHO manages to access. And what you can see here, if you look at the two maps, and I believe you're going to get access to these presentations later, if you look at the two maps, you will see what looks like a deterioration in immunisation coverage in a number of countries with the latest data. And I hesitate to say this is even complete 2021 data, because I'm not sure whether my WHO colleagues have fully signed off on the 2021 data yet. But clearly the latest information they have does show that large areas in Western Central Africa and areas in Southeast, as well as areas in Southeast Asia, the Middle East, and even in South America, there has been a deterioration in vaccination coverage over the last 2 years. This is the latest data that we have on measles for in terms of case numbers, and you can see that there's fairly consistent with the vaccination data. Where there is lower vaccination coverage, there are reported cases of measles, and this is again against the background of that caveat that I mentioned earlier, that disease surveillance has suffered a bit during the COVID-19 pandemic response period as well, and this may not necessarily be a very accurate representation of the true numbers of cases that are being suffered. Owen already quickly flashed up this map showing the larger disruptive outbreaks that have occurred in the last 12 months, and as you would expect, they're all occurring in places where vaccination coverage rates are low. And I know very well the situation, for example, in Afghanistan and Pakistan. I was active in those two countries until late 2019. Both of them have really struggled to maintain high levels of measles vaccination coverage, so it's not at all surprising that they're continuing to face outbreaks. In our immediate environment, the biggest potential risk is probably Papua New Guinea, where vaccination coverage rates are really far too low. They've not had a substantial measles outbreak for a while now, so there's a fair amount of risk. There are immunisation campaigns planned in a number of countries, but the COVID pandemic response again resulted in delays to a number of measles campaigns that were planned in low coverage areas. So we're sort of, playing catch up a little bit. We have fairly large numbers of non-immune kids in a number of countries now that we desperately have to reduce those cohorts of non-immune kids. So if we, look at things overall, what's happened, definitely measles transmission has been impacted by the measures to contain COVID-19. The lack of the reduction in contact between humans, the reduction in movement that occurred during those control measures certainly impacted on measles transmission and impacted on the numbers of cases that were being reported. At the same time, we have had a buildup of non-immune children over that period of time. In some settings where the impact where the COVID-19 response has led to a reduction in immunisation activity, we've had a more rapid build-up of non-immune kids. So as we come into a situation now where population movement is less and less restricted, and you know, we have the potential for the movement of virus, it's far more significant now than it's been at any time in the last 30 months or so. It's very likely that we will have significant measles transmission occurring in the coming 12 to 24 months. And it's also very, very likely in these settings where immunisation coverage has remained low or deteriorated that this will result in major epidemics. Now, I was also quickly asked, if I've still got a minute or two, I was also asked to very quickly have a look at something, which I will do if I can find a way of showing this without completely discombobulating my screen. Here we are. Just vaccination coverage in Australia, just having a quick look, a little bit, I suppose, checking out, I don't want to cover Tasmania up or I'll get in trouble, checking out the situation as summarised for New Zealand by Owen. There are, of course, lower coverage areas in Australia and there are lower coverage populations. In general, Australia's done pretty well at maintaining greater than 90% coverage with 2 measles-containing vaccines in kids, so that by the age of 5 years, the overall full vaccination coverage in Australia is about 95%, which is remarkably good. It has dropped slightly over the last couple of years, but not in a significant way. You can see on this map the areas where coverage is lower. They tends to be clustered in some parts of southern Queensland and in northern New South Wales. This is a single dose of measles-containing vaccine that I'm showing here. When you get onto a second dose of measles-containing vaccine, you see something of a more patchy picture. You see not only these places in southern Queensland and northern New South Wales, which still look well lower than the national average, but there are places, of course, in the Northern Territory and Western Australia and South Australia in particular, also Western Queensland, where coverage rates are lower. In general, for Aboriginal and Torres Strait Island populations, measles-containing vaccine coverage is up around 90%, but in some areas, particularly in parts of Northern Queensland, Northern Territory and Western Australia, in indigenous communities, the coverage rates are lower than that. So the vulnerabilities in Australia rest around these population areas in southern Queensland and northern New South Wales, and in some, I stress some because many indigenous communities really have very, very good vaccination rates now, in some indigenous communities, particularly in the north and west of the country. And I will stop there.
Okay, thanks, Chris. Now I've got some questions there. And Stuart, I see you wanted to answer one of the questions. Do you want to come on screen? So Dr. Stuart Jenkins, GP liaison for Waitematā and NRHCC.
Thanks, Bruce. I was just actually going to address the question to Owen, which is, what is the regional response? Is it going to involve COVID vaccinators going out into the community, or is it, making childhood vaccinations available at local pharmacies? So it's a question for Owen.
So all of the above is the answer to that question. So one of the major issues we have at the moment is that will require a workforce, and that workforce doesn't really exist in any way, shape or form, particularly the outreach one. So for example, in Waitematā DHB, there are only 3 people who are authorised to give childhood immunisation in the outreach service. So we're trying to change that. We're trying to make that process much more streamlined and more aligned with the risk profile of vaccines. So vaccines are completely safe. There's never been any harm that's ever come from them. being under-vaccinated is potentially lethal. And so we're trying to streamline that process. So one of the issues with the immunisation process is, as I said, there's no one in charge. And so we're trying to build recommendations, including how primary care. So in all of those groups that I'm on, there's a large number of primary care practices and PHOs. And so it's not just, we're not just trying to divert away from other people to away from primary care. And primary care will still be a key part of it. But they're suffering issues as well. So there's real barriers in the system to authorising people to get it done, and real issues with doing it. So that one of the major plans is to identify at-risk people and use the outreach service actively rather than waiting for the system to fail and then trying to catch up. We've already started doing that in WDHB. So that's one of the thrusts of that thing. But primary care will always be a key part of immunisation in Aotearoa. But it's fair to say that system on itself has never achieved the 95% rate in New Zealand, and we probably do need to boost the way that we do things, particularly for at-risk populations. Did that answer your question?
Yeah, seems to. Yeah, we've got some questions there about the PMS system. Does this apply just to MedTech or MedTech Evolution or other software, the catch-up tool?
Raj, can you answer that? Can Raj speak?
No, Raj can't speak. I understand it's available on MedTech. I can't answer if it's available across other systems.
Perhaps Raj could type into the...
Yeah, if you can provide an answer through the Q&A.
Yeah.
Oh, yes, here we go. MedTech 32. There's a good question here as to what has Australia done right, given the IMS rates are better? I mean, are there lessons that we can learn from Australia?
Wow, you're putting me in the hot seat, Stuart. I mean, honestly, I've only been back. I've been back in Australia now for less than 2 years, and I am gradually getting re-involved in what's going on with immunisation in Australia. But most of my work is still currently oriented towards those countries that I used to work in. I think that there's certainly been a very systematic effort to improve and sustain high levels of vaccination coverage in Australia. That's obvious. And there are groups like the NCIRS, the National Centre for Immunisation Research and Surveillance, that are essentially network groups that involve engage practitioners, universities, public health units, everything across the spectrum in the work of vaccination, gathering information about vaccination, promoting vaccination, etc. So it's a fairly visible element of public health in Australia, and I don't know enough about the New Zealand system to know whether it's comparative, whether there are things like, for example, NCIRS, or whether there's the same emphasis in public health, in the public health setting in New Zealand as there is in Australia.
A comment here from Suba from Waitematā. They have childhood vaccines connected to access to welfare and education. So that presumably you can't go to school unless you're vaccinated. Would that be, you're nodding your head there, Bryn?
No, I just agree with Suba. Those incentivizations or disincentivize in Australia, and I don't know how palatable that would be in Aotearoa, but I'm not aware. Owen may have any comments on that.
Yeah, so we don't like being told what to do. The one country that has done that part of it very well is the USA, which you can't go to school unless you're vaccinated, and they have extremely high immunisation levels. I think it would be a difficult sell in New Zealand, but I'm not against it.
When the schedule changed, a number of 2 to 4 year olds didn't realise they were due their MMR. What has been done to catch these children?
Yeah, there was I think it was mentioned that there was a full-on MMR vaccine catch-up plan, but COVID got in the way, unfortunately. So that was planned to be done, and it is still on people's workflow to do. So yeah, with a few other things.
Okay, so just one huge impact for Samoan vaccination rates was the issue in 2009 with mixing vaccine with muscle relaxant. How can New Zealand support Samoa to prevent this from happening again? How should we help people regain trust in vaccinators? How will Whatu Ora support our New Zealand staff with vaccinations?
Yeah, I was just typing an answer to that actually. So fortunately in Samoa, the vaccination rates are now 97%. There was quite a large amount of inquiries done into how the muscle relaxant even got into the hands of the people, and no one actually knows how it happens. It's a complete mystery. For example, in my ward, where we give multiple vaccines a day, there's muscle relaxant just isn't even there. I don't necessarily agree, as my presentation says, that there's anyone either in New Zealand who has a lack of confidence in the vaccine system. I think the numbers don't support that case at all. So like that, I think people do trust. For Māori, the studies we've done on Māori is that if you put a Māori in a room with someone they trust, they will get vaccinated.
Okay. In NZ, the MOH has undervalued IMS as a public health tool. Anyone like to answer that?
I think they haven't prioritised it. I think they haven't recognised it as the premier medical intervention of all time. And they've let it slide like that. And we're trying to fix that at a rate of knots as fast as we can. Anyway, so I would agree with that statement.
Catching up to late immunisation on school-based vaccination programs also.
It's a great idea. Like that. One of the main reasons that the COVID rollout in children in New Zealand was so unsuccessful is that it was not rolled out in schools, and people like me were trying to advocate very heavily that it should be done. And the reason that wasn't done is because they were afraid the schools would be inundated by protesters. But immunisations already occur in schools in New Zealand already, and I think it's the great thing about schools is that you know where the kids are between 9 and 3, so you can take the needle to them.
Measles serology, is there a place for this to assess vaccine status?
Certainly, if I can jump in, it's much better if there isn't a record, have a third one if it needs be. If there isn't a record of MMR2, have an additional one. It's easier. Yes, it can be done, but the preferable way, if there's not a record, do the vaccine.
Okay.
Of course, with a caveat, not for pregnant women or those who are immune suppressed, those where it's appropriate.
Okay, I've been getting a lot of 4-year-olds catching up their second MMR over the last couple of months due to previous schedule changes. Would they be covered against the measles, considering you talk about 2 years?
The key message, and feel free to please jump in, Chris or Owen, is some children, of course, had MMR 0 in 2019. And so we state that if they were under 12 months old for their first vaccine, they do 2 vaccines over 12 months old. And so it is possible there were some children in 2019 who had MMR 0, and so it would be ideal that they have that third vaccine because we know the immune system responds much better. They're looking at it around the world. Having said that, our statement is 2 vaccines after 12 months old.
Yeah, I mean, I think that's wise, Bryn. I think that's fine. You know, it's not a third dose of measles vaccine is not going to hurt anyone, and there is, as you say, it's you know, there is some evidence that having your vaccines after 12 months of age will lead to a more sustained immune response. So yeah, I think that's quite wise and not at all, should not be an issue at all in terms of vaccine safety or anything like that.
A comment here about the outreach services. The practices don't get notified whether the vaccines have been given or not, and they have to ring the NIR to get this information. Very frustrating.
Yeah, communication is a big issue. So I noticed there's a question further along that the Australian immunisation register is much better than the New Zealand one. It's well recognised, and an updated immunisation register is imminent. It's called the AIR, which is the Aotearoa Immunisation Register. It will have a lot more bells and whistles and be much more user-friendly, hopefully, fingers crossed. But yes, communication between services is a well-recognised major issue, and we're trying to fix it.
Comment here, there are outreach teams currently out in South Auckland every day. Is that true? Yep. They do
amazing work too. They do a great job. Incredible.
Question here, we need to find out how to self-motivate people to get their tamariki immunised.
Yeah, so that's question is looking from the gaze of a provider, not necessarily from the gaze of the person who wants to get immunised. It's the barriers are real. People, cars, places, time, money. It's true. It is really real, and people have grown up in intergenerational situations where they don't trust and they don't do this sort of stuff. And I think that the approach we've tried to take is try to look at it from the person who needs to be immunised and what their needs are, rather than why aren't they coming to X. And so that's the approach we're taking on this issue.
Presumably the decision support tool will be updated as vaccine schedules change.
We're hoping that the thing that I presented today with the immunisation catch-up tool will be the start of a large number of much better interactive digital services for immunisers to help them achieve immunisation. We're really hoping that this is the start of a wave of things like that we can use.
Comment here about secondary care in New Zealand needs to have more focus on ensuring children who present to hospital are vaccinated. If not, this should also be offered. A lot of accountability on vaccination rates lies in primary care solely, and this needs to change nationally.
Yeah, I think we could do better, and a lot of hospitals do very poorly in doing opportunistic immunisation. I'd like to think we'd lead the way in my hospital, like this sort of stuff, but I agree that it's not done well. But there's quite a lot of data to show that opportunistic vaccination isn't actually a particularly good way of preventing disease, and that the system needs to be on-time immunisation at 6 weeks needs to be the way it's got to happen, and secondary care is not going to achieve that. So although I 100% agree that those of us who work in the big hospital should be have impeccable immunisation practice, and that any child who comes into our service who requires immunisation should get it, I don't necessarily agree that that's a solution to the getting children, 95% of New Zealand children immunised on time at 6 weeks.
I know, Stuart, you've talked about having like a dashboard at the hospital level, so when somebody comes in, you can see adults or children what's missing, and perhaps, sort of try and close the loop there.
The premise is, and I think everybody would like to see some form of shared care record where there's a dashboard that identifies, no matter which door you come through, what the key elements are that people might be missing. So it might be a blood pressure for an adult for CVD risk assessment, or might be missing MMR for a child. At the moment, we don't have easy visibility across the sector, and I think the AIR is going to try and address that, but there's still a lot of work to be done in this space.
Okay, question here, probably the last one we'll take. Have Maori community groups been approached for advice or input? What are their thoughts on this? If the immunisation rates have been that much lower for Maori than other groups since 2009, without any narrowing of the gap, then we must clearly be approaching this all wrong.
Yeah, I think we are approaching it wrong, and I think that lots of Māori immunisation organisations have led the way in immunisation. Probably the most famous one was Te Whānau Waitematā, who achieved an amazing amount of COVID vaccine immunisations in Auckland, and basically with the largest single group of doing it. And all of those organisations are trying to immunise. One of the problems with immunisations is funding. The funding is quite tightly regulated, and so Māori health providers, although they give immunisations, they don't actually get funded for it. They're not able to access the B vaccination funding. Again, we're trying to change that. The process that we're trying to do is to put a bounty on the child. So if you put the needle in the kid's arm, you get the cash. That sort of thing. So it's hard for Māori organisations. If a Māori organisation comes across an unvaccinated Māori child, they do immunise them, though. It does happen.
A question here, because I think the 6-week check is a disaster point for a handover, where the midwives hand over to the GPs, and perhaps the midwives plunket could provide vaccines that are in direct contact with women at the 6-week mark, considering the 6-week mark has such significance for completion. Very stressed services, I know, of course, but I think that certainly doesn't help, does it? Owen, do you want to?
It's fair to say that midwives haven't always been the biggest promoters of vaccines, and that changed completely in COVID, and the midwives saw the risks that COVID had to pregnant women. Again, it's been an issue of funding and training for midwives to be able to do that. Sorry to cut that person off who was speaking.
No, it's just that was. I was just going to comment, Owen, that there's more to be done, I think, in connecting with midwives. And for example, they're not connected into med-ins. And I think if we were to do some simple things like that, that would start to be a step towards, seeing better discussions with LMCs around immunisation and how they can support it.
Well, we've hit 8:45, folks, so I think we'll draw this to a close. So I'd just like to thank our speakers, Owen, Bryn and Chris, and for extra comments from Stuart. So thank you very much. Been some good questions there that are coming in, and we hope we're able to do better with our immunisations going into the future. So thank you, and we will close the session now.